Three, two, one. Sir, we are live now. Now we can start the meeting.
Good evening, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have Dr. Ritabh Kumar sir, who is teaching us about DVT. Sir is from Indian Spinal Injury Center, New Delhi, and I think now, without wasting any more time, we'll over to sir. So,
Thank you.
please, sir.
Good evening, participants. Feel free to ask any questions in between Dr. Janki. So the topic is venous thromboembolism, and especially in relation to trauma. And the question is it really silent? So, sorry.
Yes, sir.
Yeah. So deep vein thrombosis, as we know, is formation of clots in the venous system of the lower limbs. It can form in the upper limbs, but we generally talk about the lower limbs and the pelvis area. The reported incidence from Western literature in trauma patients overall is around 60%. So the fundamental question to ask is, where is the clot? Is it proximal or also called central? That is above the knee or below the knee? If it is below the knee, this is what is seen in majority of the cases. They are largely asymptomatic. The risk of loosening and going upstream is very low. In such cases, prophylaxis is generally not recommended. And if the deep vein thrombosis is picked up, a repeat Doppler after 7 days is recommended to check the status. And usually more than 90-95% of the clots generally resolve on their own. When the clot is dislodged from the leg above the knee or the vein, pelvic veins, and goes and gets stuck in the pulmonary artery, that then causes a right heart failure. It causes a backlog on the right heart. Although the incidence of pulmonary embolism, again from Western literature, is reported to be 25%, most of it from the proximal or central clots, clinically relevant embolism is seen in less than 3% patients of trauma worldwide. Another neglected aspect of deep vein thrombosis is the localized long-term morbidity. Once a deep vein thrombosis develops and over time resolves, the veins become thicker. When the veins become thicker, the flow of blood becomes slower. So most of these patients end up having some distal edema in the limb. You must have seen patients complaining of swelling in the legs after plaster cast removal or after surgeries. So they probably have some subtle form of calf DVT, which is taking a time to resolve. Hyperpigmentation of the skin basically suggests that the venous pressure is a little high and blood has seeped out from the veins and is tattooing the skin, as you can see in this case. This eventually causes reduced muscle stamina. So even after DVT resolves, it leaves behind long morbidity locally. So what does trauma do? Does trauma cause bleeding or does trauma cause clotting? That is the question. So if I may ask the participants, in your opinion, in the first 24 hours of injury, what does trauma do? Bleeding or clotting?
So initially bleeding, then clotting.
So when does this transition from bleeding to clotting happen? Very right, you are very right. So initially bleeding, yes, very right. So
So
we'll
when,
go. Sorry, Ranjan?
so when there is when the leukocytes and platelets come and
Yes. Yes. So you have got a good idea. We'll see it in detail. So there is this term called trauma-induced coagulopathy. After trauma, the risk of bleeding is higher. There is a broken bone, muscles are torn, so bleeding is higher. So because of bleeding, there is a loss of coagulation factors from the blood. When we give IV fluids, it dilutes the factors that are remaining in the blood. Most of the trauma victims eventually develop low core body temperature. This slows down the enzyme reactions of coagulation. And if certain areas of the body are hypoperfused because of low blood pressure, lactic acid is produced, which causes acidosis. Acidosis further slows down the coagulation cascade. So, after trauma, there is a transient increase in the risk of bleeding at the area of injury. The more severe the injury, the longer this is likely to exist. As in this case, there is massive pelvic fracture. So the severity of the injury is significant. The patient must have bled significantly, must have been given fluids, loaded with fluids. So the important thing to remember is most of these patients, the risks of bleeding reverse within 24 to 48 hours if they are well resuscitated. If such patients are not resuscitated, they will eventually die of bleeding. But once they are resuscitated and they survive, after 24 to 48 hours, something happens. And from becoming hypocoagulable, they become hypercoagulable. So this is the natural history of blood clotting in a trauma victim. Initially, as you can see, the patients are hypocoagulable. After a certain time, they become hypercoagulable. Later on, depending on the recovery, some patients may go into disseminated intravascular coagulation or multi-organ dysfailure, and the risks of bleeding may again increase subsequently. So trauma and DVT, what we know for sure is most of the patients don't have severe trauma. Most of the patients that we see have, say, isolated tibia fracture, a femur fracture, a humerus fracture, a distal femur fracture. That's what intertroch fracture. So more than 90% trauma victims that we see are not severely injured. So they are hypercoagulable at presentation. They have an increased risk of clotting happening because after fracture, the limb does not move. The limb cannot move. There is venous stasis. So more than 90% patients are hypercoagulable. The risk is higher, obviously, in lower limb injuries. The peak incidence of clot formation is at 7 days and then around 5 weeks. The first week and 5 weeks. In some cases, like a spinal cord injured patient with fractured femur, where there is an element of paralysis, the risk may be as high as for 14 weeks. So up to 90 days, the risk may remain. The important thing to note is that DVT can also occur in the uninjured limb, the opposite limb, in 30% cases. So that is why when a Doppler is requested for, we ask for bilateral lower limb venous Doppler. Now, these are facts, these are undisputable. The good thing is that trauma is essentially a transient risk factor. That is the important thing to note. Paralysis prolongs the risk duration, and the key strategy after any trauma surgery is mobilization, because mobilization dramatically decreases the risk of DVT. So this is the Verkos triad which is we are all familiar with. So if the patient after trauma is hospitalized, so he's essentially bedridden. So if the patient is bedridden because of a broken bone, there is venous stasis. Because of the injury, there is endothelial injury, and the patient is hypercoagulable. So we have all the three elements of Werkos triad working against the patient. So when we talk of all hospitalized patients, they are generally at increased risk compared to the community. That's obvious. But amongst hospitalized patients, the most increased risk is seen in these three specialities. Medical, where the patient is in the ICU and not able to move around. Oncology because of tumor with its own reasons. And amongst orthopedics, it is the highest risk is seen in major lower limb trauma and polytrauma victims. Most of the THR and TKR patients usually come walking to the hospital, limping, lurching to the hospital. Trauma victims are brought on trolleys to the hospital and are not able to move. And the higher the trauma volume, the higher the immobility. The important thing to remember is trauma is a transient risk factor, and this risk gradually settle down over a period of time. So what we have learned so far is that more than 90 patients of normal routine trauma are actually at increased risk of clot formation at presentation. The only very sick patients are at risk of bleeding, but they become hypercoagulable after 48 hours. The risk of venous blood clotting is transient, but a tangible risk factor for 5 to 6 weeks in most of the patients. And the key strategy is mobilization. So when we talk of DVT after trauma, like I said, there is an early phase and a late phase. In some patients like spinal cord injury, paralysis, nerve injuries, and the limb cannot be moved even after fixation, no active muscle contraction, the risk remains for as high as 12 weeks. Why I have drawn an asterisk, we'll know at the end of this slide. So certain factors predispose the patient to increased risk of clotting. The heavier the patient, the more obese the patient, high BMI predisposes the patient to higher risk of DVT. The elderly patients are at increased risk compared to younger people. When we talk of disease specific amongst trauma, paralysis, malignancy, patients with pathological fractures are at increased risk. Lower limb fractures, major surgery over 3-4 hours. And subsequently, if the patients get infected, they are increased risk of clotting. So in high risk cases, we can extend prophylaxis up to 12 weeks or till the patient can be mobilized comfortably. So what is the concern with DVT? The concern is a high incidence is reported in Western literature. They also implicate that once embolism occurs, it's devastating. It can cause almost an acute death. The complications localized to the limb following DVT of post-thrombotic syndrome generally are understated and neglected. The question is it largely silent? So the key to catching the clot is in awareness. So silence. What is this silence due to? Either not knowing, or why not knowing? Because traditional teaching, as per literature and what I was taught, is that this is a Western phenomena. हमने कभी देखा नहीं है. Postmortem is very uncommon in our part of the world. So we really never come to know the real cause. DVT may occur after 5 or 6 weeks. If the patient does develop a problem after discharge and comes back to the hospital with breathlessness, the relatives may take the patient to a different department who may not report back to the orthopedics, and so we may not be aware of this complication. Either the risk silence is due to not knowing, but it may be due to knowing, but not being able to do something. So why is this? Why have I put this? Although I know, the question is venous Doppler is required for the diagnosis. The question is its availability. The second is a cost issue. A venous Doppler bilateral lower limb costs around 4,000 rupees. Like an X-ray, question is how many times can we order it within the first 3 weeks or 4 weeks? Once patients are discharged, generally within 4-5 days, it becomes difficult to then get a Doppler on OPD basis. So even if we know, the question is, what can we do about it? So the key strategy is prevention. After knowing that, okay, it may occur, the key strategy is prevention. Prevention, basically, I have highlighted 3 points. First is risk stratification. Let's quantify what is the chance of a particular patient developing this complication. Okay, we have put a certain patient at high risk. How can we avoid DVT from forming and embolizing? And the third is the diagnosis. So there are many risk assessment criteria scores, the Caprini score, the Geneva score. So I have just put one score here to highlight that you may pick up any one score from the literature and modify it suitably for your local population, but do have a score. Any nurse or technical assistant can do this scoring in less than 3 minutes. So if you have stratified the risk, you know, okay, this patient is at increased risk. Then comes deterrence. Now, deterrence could be mechanical or chemicals. In chemicals, you have ecosprin. You must have heard of low molecular weight heparin and injections and tablets. So the question with mechanical is, are they effective? And the question with chemicals is, will they cause bleeding and interfere in the healing process? So when we talk of mechanical, we basically talk of stockings, graduated compression stockings, GCS, or thromboembolic deterrent stockings. So when we look at stockings in detail, they have graduated reducing pressures as we progress proximally. So at ankles, it is 18 millimeters of mercury pressure via the stocking, calf 14, thigh 12. Now for stockings to work effectively, muscle contraction is essential. So in a patient with paralysis, stockings become detrimental. They will not help. They are there for cosmetic reasons. The other is pneumatic compression devices. They are intermittent. They have bilateral inflatable stockings, and different cells of the stocking inflate sequentially and deflate sequentially. So the pressures here, the cells are inflated up to 40 millimeters of mercury for 10 seconds, and then they deflate over 50 seconds. The biggest challenge is the mechanical devices have to be worn for at least 18 hours a day, and not everyone is comfortable with this. In the graduated compression stockings, if the pressure becomes higher than 20 millimeters of mercury locally, there is a high chance of subcutaneous ischemia. The skin may not get its blood supply, and that in itself can cause a wound breakdown. In our part of the world, with summers at its peak, with sweating happening, it becomes a challenge to wear a stocking. So compression stockings, like I said, increase the risk of subcutaneous ischemia. And if they are above knee and improperly applied, they in fact become a tourniquet to the skin, as you can see in this case. In the upper part of the thigh, the stocking has crumpled up and it actually is counterproductive. And this, in fact, would increase the risk of deep vein thrombosis. So it's cheaper alternative. These stockings cost around 3,200 rupees. And 99% they are not worn properly because putting it on is cumbersome. Taking it off is cumbersome. Generally, the thigh swells up after the middle level, and these stockings are usually worn till here because the patient feels comfortable. The attendants are not able to push it up. The stockings may get soiled in urine, especially in patients who are paralytic, so it defeats the purpose. We came up with a local, cheaper alternative, but as you can see in this case, a crepe bandage is applied sequentially, tightening from below upwards, but when the patient flexes the knee, the effects are reversed, and in fact, the purpose is defeated. Overall, in my experience, there is a very poor compliance with these, and these essentially are not as effective. So when we come to chemicals, we talk of injectables and orals. In injectables, we have low molecular weight heparin, which is considered at present, as per literature, the gold standard. They are the most efficacious. They are reasonably safe, once daily dosing, and no coagulation testing is required. That is the benefit of low molecular weight heparin. When we talk of orals, we have aspirin, 75 milligrams, and oral low molecular weight heparins, which again are once in a day. They are also one daily, no coagulation tests required. They are safe, equally efficacious. They are basically non-inferior to the injectables. So when it comes to diagnosis, we need a venous Doppler. So in this case, you can see the right common femoral vein and the left common femoral vein. There is a blood clot in the left common femoral vein in this patient. So I asked the radiologist, so the answer is, what do they look for? They look for flow of blood in the vein. The vein is next to the artery and there should be a flow of blood. In DVT, the flow slows down. Veins have thin walls, and even if they are deep, if you push down on the vein with the probe, the veins are easily compressible and the flow drops down to zero. And the moment the probe is taken off, the pressure is off, the flow returns. So if the veins are no longer compressible, the chances of DVT or a clot formation there are high. Distal to the limb, distal in the limb, distal to the probe, if the leg, foot, leg, thigh is squeezed, there is an increase in the blood flow in the vein. So that is known as augmentation. That is missing if there is a clot. And apart from what we can see, what we hear is slow monophasic flow of blood, as you can see in the Doppler pattern below. I'll take you one slide back to show you the flow of the blood in the vein in the right common femoral vein. It has a flow, it is fluctuating, but when there is a clot, the flow has slowed down. There is a sluggish, slow monophasic sound of some flow happening. It should be done in both the lower limbs. That is the crucial take-home point because of a 30% incidence of opposite limb DVT. So this is the final slide of what I have learned so far in my experience, and what I practice is, yes, the risk of DVT is real, especially after acute trauma. We must give chemical prophylaxis to at-risk patients. If the risk is high, the patient is in hospital, give injectable low molecular weight heparin. At discharge, we can switch over to oral. In oral, if the risk is high, I prefer to give epaxiban for 42 days. Otherwise, most of the lower limb patients get ecosprin, 75 milligrams daily for minimum 42 days. 45 days course of ecosprin costs 15 rupees. That is important to remember. 15 tablets cost 5 rupees. Whenever there is a delay to surgery, I get a venous Doppler of both the lower limbs pre-operative. Although the patient is on prophylaxis, we still get a Doppler done. The fundamental issue is to balance the risk of bleeding versus clotting. And most of trauma victims in the initial stages are at risk of clotting. The biggest unanswered question, which I have not written down here, but I leave open for discussion, is what if the patient has a DVT pre-operatively? Then what to do? Thank you.
Thank you very much, sir. Even we are
So I will
waiting
now
for.
invite questions and comments
Yeah.
from the participants on the last question, which I have intentionally not touched upon.
Yes, I think.
Dr.
Mm.
Janki, in your opinion, if you get a clot before surgery, say the patient has a fractured tibia, you're suspecting DVT, you get a DVT Doppler done, and there is a clot, what would you do?
That usually will involve the multidisciplinary approach, sir, first,
Yes.
and usually with a physician and TTVS
Whatever
people.
happens, Janki,
Sorry, sir.
what I have seen is no matter whom you involve, everyone
Yeah.
comes and says there is a risk of clot embolizing and you can die. So no matter what the fracture is, no
Yeah.
matter what you have counseled, at end of the day, someone from the physician side or anesthesia side just has to say this,
Yes,
and
yes,
99% patients run away.
that's true, sir.
So this is where our hands are tied. Most of us are not working in a safe environment of a government hospital or a large hospital where there are people who can say that, yes, the risk is real, but we will take care of it. Most of us are in private practice and no one wants to take a risk. That's the sad thing. So we have lost not many patients have gone away of mine because of DVT, fracture femur, left without treatment. Called them up, they said they are like that in bed for 3 months now. Ankle fractures, tibia fractures. Any questions, comments?
So I think participants, if you have any doubts, you can ask. So one more thing, which is commonly for the UGs, when to start that prophylaxis if we are planning for like hip arthroplasty? When ideally it should be start, when should be stopped, and when again to be started? For how many
See,
weeks?
generally patient has come walking to the hospital or limping to the hospital in arthroplasty cases. So as soon as you do the surgery, 6 hours after the surgery, you can start the prophylaxis. The question is, how long do you give that prophylaxis for? That depends from patient to patient, hospital to hospital, doctor to doctor. So I have not read many guidelines about arthroplasty patients, so I cannot comment on that. But for trauma, I can say that suppose, let's say there is a fracture femur in a young person, 40-year-old, who has started walking with a walker and who's reasonably comfortable by 5-6 weeks. We can stop the prophylaxis at 42 days. Now we had a lady with, let's say, bilateral femur fracture, atypical femur fracture, bilateral. 70-year-old lady, bilateral atypical femur fracture. Now this is a little different scenario. So here we give the DVT prophylaxis, same ecosprin for about 12 weeks.
So I think just after operation also you start with ecosprin, but should be the preferable drug, sir, or
Yes, generally early post-op 6 hours, the patient has not taken anything to eat or drink. So patient is actually not so comfortable. We don't want to give ecosprin or tablet. So we give an injectable. We give injectable for 3 days and start ecosprin the first post-op day. So there is an overlap of 2 days between ecosprin and the low molecular weight heparin.
So it's 75 only, sir.
75. 75. If the body weight is a little higher, of say 90 plus, then we give 150.
Okay, sir. Yeah, because sir, I think a few years back I have read what US guideline. There it was the effect was almost similar for 75 and 150. They have written.
Yes, yes. In some countries, they also have 37.5. Netherlands has 37.5. There also it is effective, but then again, body weight, it depends on the body weight.
Okay.
One common question I'm asked is, if patient is on clopidogrel, then why do we need ecosprin?
Yeah.
Clopidogrel is a more
The
powerful,
antiplatelet.
more effective blood thinner. Then why do we need ecosprin? So clopidogrel is essentially a very good blood thinner, but it works in a high pressure system. So clopidogrel basically reduces arterial risk of arterial thrombus. So heart में venous thrombosis नहीं होता, arterial thrombus होता है, which causes the problem. And orthopedics में venous thrombus होता है, तो ecosprin is more effective in the low pressure system. So that's the reason. So even if the patient is on clopidogrel, after orthopedic trauma, it is wiser to start the patient on ecosprin also. So clopidogrel is good for the heart, not the legs.
And even during the post-operative period, if someone already developed the DVT, the signs of DVT, then what is your the management?
Yes.
How
So suppose patient is at risk and we feel that there is DVT suspected, we get a Doppler. Doppler shows DVT.
Yeah.
So what we do in such cases, is it proximal or distal? If it is distal, the patient is
distal to the
continued
knee
on,
joint.
sorry, distal to the knee joint or proximal to the knee. So if it is distal to the knee, it is a distal DVT. It's not a high risk. So we tell the patient, please keep taking your ecosprin. And we'll review this after a week, 10 days. We will repeat the Doppler and see what is happening. Most of them usually resolve. But if there is a proximal DVT, then the patient is admitted. We request the patient for admission. Sometimes they get admitted, sometimes they don't. If the treatment is, we give injectable low molecular weight heparin twice a day for 5 days. And the second day onwards, we start dabigatran. Dabigatran, 150 milligrams BD. So that is then given for minimum 3 months.
Okay. If someone develops it.
If someone develops proximal DVT post-operatively, Doppler पे proven हो गया है, तो we give injectable fragment or low molecular weight heparin twice daily for 5 days. On the second day of admission, we start oral dabigatran, and that is oral is continued for 3 months. We do a repeat Doppler in between at 3 months, and then depending on the resolution, dabigatran maximum recommended is to continue up to 6 months to reduce the risk of post-thrombotic syndrome. Once it is 3 months, reduces the risk of embolism dramatically, but the next 3 months is to reduce the risk of post-thrombotic syndrome.
So, in case of if someone is having suspected cellulitis after post-operative period, do you still suspect that chance of DVT? Because one of the patient, when I think retrospectively after arthroscopy, he was discharged, and within 3 or 4 days he came back with cellulitis. Although we have treated on the basis of I have taken the surgery opinion and all, and that the main treatment was for cellulitis they have given. Although he improved and went back after about 2 or 3 weeks. Is it that possible that he has DVT also? Because we have
Unless we
not.
don't look for it, we will never know about it.
Yeah.
So it's always wiser to get a Doppler done. And believe me, you ask surgeon, you ask physician, they have no idea. You have a better idea of your patient than them. So many of the other doctors, they come and give insensitive opinions because they are not directly responsible for the eventual outcome of your patient. You are directly responsible for what is happening. So you have to increase your knowledge base. You may take opinions from others, but at the end of the day, you are the captain of the ship.
As you told, sir, they usually come in different department.
Yes. So
So
if they
that is
come
the
in different department, you are not aware, you cannot do anything.
true.
But if you come to know of it, patient connects with you, it is always good to go check the patient and request do a Doppler. And if it is proven, so मेडिको लीगली स्पीकिंग होता क्या है कि अच्छा वेन का प्रॉब्लम है तो वैस्कुलर के पास जाना है.
Yeah, true.
अब फ्रैक्चर ह्यूमरस हुआ है, रेडियल नर्व पाल्सी हो गया है, दैट डजंट मीन यू गो टू अ न्यूरोलॉजिस्ट. बट
Yes.
medically speaking, because nerve is involved, court will ask, did you ask a neurologist? So you have to do certain things for being medico-legally correct because times are changing. Doctors no longer are respected. So you have to do certain things that are medico-legally appropriate. But at end of the day, you have to do things which are right for the patient, not right for the court and the files. So my answer would be request for more Dopplers. You may start picking up DVT. Talk to your radiologist, stand with them, see what they are doing. And once you are wiser, it will make them wiser. And once you are wiser, you have seen it, you have treated a patient, and the patient gets well, you will have the confidence to treat more. You can diagnose more, you can treat more, and you can get them back to normalcy.
Yes, sir. So, how often you give DVT prophylaxis in trauma case, sir? Is it some
Everyone.
criteria?
No,
Everyone,
everyone.
even in younger
Above 18 years of age, or all lower limb trauma.
all lower limb trauma above
Yes,
18 years.
again,
Yeah.
medico-legally, that's the indication. Suppose something goes wrong and you have not given it, then there is no defense. So
Yes.
above 18 years of age, acute trauma, 99% patients, like I said, are hypercoagulable till they are mobilized well. So if suppose there is a patient with ankle fracture and we have mobilized them, mobilization means full weight bearing walking, not hopping or non-weight bearing. Non-weight bearing, the risk of DVT remains high. So there has to be full weight bearing. So the issue arises if you have done a distal femur, proximal tibia, pylon, then what? You cannot mobilize them full weight bearing. So they are the kind of people who are at increased risk because you cannot make them put full weight for 6 to 8 weeks. So that's where we give ecosprin for a longer period. But diaphyseal femur, diaphyseal tibia, you can make them bear full weight. So there you have to give a shorter duration of prophylaxis.
Sir,
So,
I have a question.
yeah, any question?
Sir, if patient came with polytrauma, sir, you said ki in acute cases of trauma, we have to start this anticoagulant, sir.
Mm-hmm.
So if patient came with polytrauma with like the pelvis trauma and leg trauma,
Mm-hmm.
so and bedridden, he is bedridden. So
Mm-hmm.
should we start coagulation anticoagulation therapy? Like,
Good question. So let's say pelvic fracture है और leg fracture है, तो आप मान लो बहुत बढ़िया काम कर रहे हो, आपने सर्जरी भी कर दी, तो सर्जरी कर लिया, लेग फ्रैक्चर फिक्स कर लिया, तो 3-4 दिन तो निकल ही गए. बहुत बढ़िया करा, उसके बाद खड़ा भी करा दिया, तो 5वें-6वें दिन तक ही खड़ा करा पाएंगे. चला
yes,
पाए ना पाए वो अलग बात है, बट खड़ा ही कराएंगे तो 5-6 दिन बाद. सो पॉलीट्रॉमा में जनरली दे आर at risk of increased bleeding for the first 24 hours. So first 24 hours, no clot, no anticoagulant.
okay, sir.
Once the patient's vitals are stable, urine output is good, then the risk of coagulation starts increasing. So ऐसे patients में there is no blood investigation that will help you.
Okay, sir.
Blood investigation will tell you कि इसका blood hypocoagulable है, INR delayed है, PT delayed है. but no blood test will tell you that his blood is hypercoagulable. ये क्लॉट होगा, क्लॉट नहीं होगा उसके टेस्ट हैं, क्लॉट होने के टेस्ट नहीं है अभी हमारे पास। तो हमको मान के चलना है कि क्लॉट होगा 48 घंटे बाद, तो देन वी स्टार्ट एंटीकोगुलेंट।
Okay. Thank you.
राइट।
So, one more thing is it that like in a young patient with femur fracture, the chances of fat embolism, what
हाँ,
usually we
yes.
suspect, is that DVT and fat embolism also goes hand in hand in some cases, or
हाँ, yes, they can overlap significantly. जैसे मैंने कहा डीवीटी का पीक आता है 7 days पे, फैट एम्बोलिज्म का 24-48 आवर्स में। तो हिस्ट्री को, टू टेक द हिस्ट्री एंड द सीक्वेंस ऑफ इवेंट्स इज वेरी इंपॉर्टेंट।
so like as you told, in younger patient, if it is after a week, even that patient gets worsen or that symptoms has appeared, then we should
थिंक
be
ऑफ
more
डीवीटी,
okay, sir.
24-48 आवर्स में फैट एम्बोलिज्म,
or
7
other
days पे डीवीटी।
true, sir.
डीवीटी विथ एम्बोलिज्म, डीवीटी का अपने आप में पता नहीं लगेगा इतना,
Yes.
अदर देन पेशेंट सेइंग स्वेलिंग है, तो स्वेलिंग को कौन इंपॉर्टेंस देता है? फ्रैक्चर है तो स्वेलिंग तो होगा ही,
Yes.
प्लास्टर में है तो स्वेलिंग दिखेगी भी नहीं मान लीजिए। सो
Yes.
व्हाट कैन वी डू टू पिक इट अप? वी हैव टू बी अवेयर। बहुत बॉडी मास इंडेक्स हैवी है, हैवी पेशेंट है,
Okay, sir.
आजकल ओबिसिटी भी बढ़ गई है, हैवी पेशेंट है, तो बेटर टू गेट ए डॉपलर डन।
Sir,
The
as
one
you
more-
said, कि there is swelling in lower limb. Most of the if there is patient with IT intertrochanteric fracture
यस,
or any lower limb fracture and fixation after post-op day, one patient is saying there is a swelling in my lower limb.
यस, यस,
So we used to say do the exercise or
यस,
limb elevation and this muscle contraction and
यस,
relaxation therapies.
यस, यस।
So in that condition, matlab, we go to on the way to DVT or the normal there is
नहीं
edema
नहीं,
swelling this thing.
क्वेश्चन इज 4000 की टेस्ट है आपके यहाँ, चलिए मान लीजिए 2500 में हो जाता है, चलो और मान ले 2000 में हो जाता है, कितनी बार कराओगे? सो प्रैक्टिकल चीज है कि अज्यूम करो कि देयर कुड बी एन एलिमेंट, गिव एकोस्प्रिन एज ए ब्लड थिनर, दैट इज एटलीस्ट रिड्यूसिंग द रिस्क ऑफ डीवीटी सिग्निफिकेंटली। बट मोर इंपॉर्टेंट दैट इंटरट्रॉक फ्रैक्चर है, फिक्स कर दिया है, मेक दैट पेशेंट स्टैंड अप। When the
Yes.
foot veins, when the veins in the foot are compressed, that significantly reduces the risk of DVT. इसलिए आपने फुट पंप्स का नाम सुना होगा, तो
Yes.
मैं आपको सुझाव दूंगा कि मान लो एकोस्प्रिन तो हर कोई अफोर्ड कर ही सकता है, 15 गोली 5 रुपए की आती हैं, बाकी महंगी दवाइयां हम ना कर सकें, तो एज ए मैकेनिकल डिवाइस मैं क्या करता था, जो ब्लड प्रेशर का इंस्ट्रूमेंट है वो कफ फुट पे लगवा देता था पेशेंट के, और रिश्तेदार को कहता था कि हर घंटे में इसको फिसफिस मारते रहो 8-10 बार, टेक इट अप टू 60 millimeters of mercury, होल्ड इट देयर एंड देन रिलीज इट।
Yes. Okay.
Foot pumping is more important than calf pumping or thigh pumping.
Thank you, sir.
Okay.
So, one thing, sir, if someone is already diagnosed with DVT, in that case, what is the protocol for exercise or ambulation?
So there is limited mobilization for the first 7 days, just for toilet privileges. Walker के साथ आप toilet जाइए और take rest. 7 to 10 days. Repeat a Doppler. Like I said, the first 7-10 days are high risk for embolizing. So after 7-10 days, you can mobilize them in and around the house. हाँ, मॉल में घूमने घामने मत जाने देना, घर में चल फिर सकते हैं। 7-10 days बाद they can mobilize well.
Okay.
And the first 7-10 days, they are at increased risk.
Like log rolling and all, करवट बदलना ये सब
हाँ,
करवा
that's okay. वो इतना हम बहुत ज्यादा, we end up scaring the patients too much, actually.
तो एक क्वेश्चन जो कॉमनली डीएनवी वगैरह हम पूछते हैं, आईवीसी फिल्टर रेटिकल,
हाँ।
ऑल्दो
So,
even we have not
yes,
seen
so
that.
मान लीजिए
So,
the patient has some derangement of coagulation and cannot be given anticoagulation.
yes.
कि PTINR delayed है और coagulation ये anticoagulant देंगे और delay हो गया है. That is 1 in maybe 10,000. Patient has some bleeding disorder and you cannot give anything. Then what is it that you can do? So that is where IVC filters have a role. So IVC filters can be placed, but they are temporary. They have to be removed because if they are left in for long, they themselves, as a foreign body in a vein, can cause DVT and a central DVT which can embolize.
Mm.
So they are temporary. You can use them. हमने 2 बार ही करा है. कोई एक अमेरिकन पेशेंट आ गया था विद फ्रैक्चर फीमर who had broken her bone in Nepal, 74-year-old, who came to us after 5-6 days, and she had DVT and a fracture femur. So we used the cardiologist's help to place a filter. We operated the femur, and then we sent her back to USA. And from there, the doctors there then they removed the filter at 3 months. कई बार 6 महीने 8 महीने छोड़ दो, 1 साल, तो निकालना टेढ़ी खीर हो जाती है.
तो यूजुअली मतलब वो रेयरली ही होता होगा सर. कितना कॉस्टली ज्यादा है सर या?
नहीं, इट्स नॉट अ कॉस्टली. इट्स लाइक स्टेंटिंग जैसे करते हैं वैसे डाल देते हैं.
ओके. तो
एंड वो अराउंड 70,000 रुपीज का आता है. प्रॉब्लम डालना नहीं है, प्रॉब्लम वो ढीला होके निकल गया फिर.
ओके.
वो भी तो चीजें हैं. तो डालते वक्त लोगों को एक्सपीरियंस नहीं, तो डालने वाले भी डरे हुए होते हैं.
ओके.
तो यूजुअली दे विल से नो 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 नो, तुम LMWH दे दो, ये मत डलवाओ.
So if someone have more question, you can ask directly. किसी का और कोई क्वेश्चन है? प्रत्युष, राजन, रिशु, I think
अच्छा,
if there is no more question, then
ठीक.
it was great,
Sir,
sir.
if you can again emphasize on the symptoms of the DVT versus the symptoms of the pulmonary embolism, sir.
सॉरी.
Pulmonary embolism.
Pulmonary embolism basically it causes sudden right heart failure. ब्लड प्रेशर एकदम ड्रॉप डाउन हो जाता है एंड ब्रेथलेसनेस मिनट्स में, लाइक अ हार्ट अटैक.
Yes, sir.
And
And
that
that
is
happens in a
almost
massive embolism. So
almost always fatal, no
वो
sir?
1 in 1,000 है, इंस्टेंटेनियस डेथ. यूजुअली समय मिलता है, ब्रेथलेसनेस शुरू हो जाती है पेशेंट को. राइट हार्ट फेलियर है, ब्रेथलेसनेस शुरू हो जाती है. तो ऑल दैट यू डू इज सपोर्ट, ऑक्सीजनेशन दो एंड लो मॉलिक्यूलर वेट हेपेरिन की डोज बढ़ा दो. समय लगता है, एवरीथिंग सेटल्स डाउन विद टाइम.
Sir, one thing, the D dimer, sir, we test for D dimer.
हम्म.
So it is useful for pulmonary embolism or the DVT. मतलब in pulmonary embolism it is there, but in DVT, what is the use of D dimer doing any use, or this is like for pulmonary embolism only?
ये आजकल बच्चे बड़े सारे टेस्ट करवाते हैं, फिजिशियन भी जम के लिखते हैं. सो ये डी डाइमर बेसिकली is a test which generally increases after trauma.
Yes, sir. मतलब
Any trauma, it will increase. So,
yes.
किसी को मसल इंजरी हुए तो बढ़ जाएगा. So, हमारे ICU डॉक्टर्स बहुत करवाते हैं. I don't get it done.
Okay.
In my opinion, if there is a doubt whether this patient needs prophylaxis or not, and risk factors suggest high risk, but I am not convinced, then you can ask for a D dimer. But then my option is very simple. If I feel the patient is at higher risk, I give ecosprin. 15 गोली 5 रुपए की है.
Yes.
सस्ता देन डी डाइमर.
Very.
ठीक है ना?
Yes, sir.
Do something which does not hurt the pocket of the patient. Do something that helps the patient, and do something that is scientifically valid. Yes, it may not be as effective as LMWH, but at least it is better than doing nothing at all. So, फॉरेन कंट्री में जहाँ कॉस्ट इज नॉट ए कंस्ट्रेंट, रिच लोग हैं, डेवलप्ड वर्ल्ड है, दे विल गिव LMWH इंजेक्टेबल और टैबलेट. वी कैन नॉट अफोर्ड दिस इन ऑल आवर पेशेंट्स. सबको देने लगेंगे तो द कॉस्ट ऑफ प्रोफाइलैक्सिस विल बिकम, लेट्स से LMWH एक इंजेक्शन 500 रुपए का आता है, 40 दिन दोगे तो 20,000 तो इसी का इलाज हो गया. नॉट प्रैक्टिकल. टैबलेट दोगे तो टैबलेट भी 20 रुपए की एक आती है, तो 1,000 रुपए का हो जाएगा.
तो प्रोफाइलैक्सिस में इकोस्प्रिन और थेरेप्टिक है, तब LMWH
एकोस्प्रिन एंड मोबिलाइजेशन.
यस ट्रू सर.
हमारे शहर में भी
early.
बहुत लोग यहाँ IT फ्रैक्चर कर रहे हैं, दिस इज नॉन वेट बेयरिंग टू लाई इन बेड फॉर 3 months. That is not what is recommended. Giving LMWH and keeping patient in bed is not recommended. Idea is mobilize them. The key strategy is mobilizing. Fix well and mobilize.
Sir, DVT is like it's better to prevent it than diagnose it.
Definitely. Diagnosis का खर्चा कौन सा इजी है?
Yes.
फ्री में थोड़ी ना होगा. एक्सरे का तो पेशेंट को आइडिया है, कहेगा बार बार अल्ट्रासाउंड करा रहा है पैर का,
Okay.
है ना. सो लुक एट द लॉजिकल एंड प्रैक्टिकल एस्पेक्ट्स. हर जगह आपको मिलेगा डॉपलर. डॉपलर आपके हॉस्पिटल में हो सकता हो, प्राइवेट प्रैक्टिस में आपका वो डॉपलर वाला होगा 5 किलोमीटर दूर. पेशेंट कैसे जाएगा फिर आएगा?
Yeah, we are lucky to have that one, sir.
हाँ.
And
So not
held
everyone is
Doppler
working in a big center, so one must be practical also.
Yes, true, sir. So I think it is great, sir, and
Thank you.
we have learned a lot, and I think
Thank you.
most of the practitioner also will gain something from it. So
जी.
thank you very much, sir.
Okay. Namaste.
Thank you, sir.
Namaste.